Testing. Hi guys, welcome back to module 10. We're in week 10 now, and our module that we are currently in is neurology. I'm so happy that we are finally at week 10, guys. We're almost there to the finish end. I'm so proud of you. So let's continue. So in this module, we are focusing on chapter 8, which was degenerative disorders, which we included Alzheimer's disease, Parkinson's disease, and ALS, also known as amyotrophic lateral sclerosis, or very commonly known as Lou Gehrig's disease. We also focused on chapter 9, which was cerebrovascular accident, CVA, or stroke. So those were your readings from your primary care textbook. Then you had chapter 19 out of your neurology practice guidelines, out of your CASH textbook, which included Alzheimer's disease, Parkinson's disease, and stroke guidelines. The other supplementary materials that I included within the module include PowerPoints from the Alzheimer's Disease Research Center, which include 2 different PowerPoint presentations. One is on healthy and unhealthy brain aging presentation, as well as another presentation on clinical essentials of AD and related dementias. I included a guide to Parkinson's disease from the Parkinson's Foundation, directly uploaded from them. It is a guide that is actually meant for patients, but I find it is actually a beautiful way of describing the disease, both for the clinician and the patient, in a very simple to understand way of describing it, with a lot of very interesting information, including differentiating Parkinson's from Parkinsonism. I also included a podcast. There are podcasts on the Parkinson's Foundation website. Please check it out. They're always continually updating their podcasts and all of their informational resources on that website, as well as on the Alzheimer's disease website. Both websites provide a tremendous amount of information, not only to patients, but to clinicians as well. So keep yourself up to date with the most recent research and guidelines by checking out these particular websites pretty frequently. I included a podcast episode on the multidisciplinary approach to Parkinson's disease. Please listen to it. It's only about 15 minutes, but it just gives another interesting perspective on how to deal with Parkinson's. I included quite a few YouTube supplementary videos, so please check those out. They're all just helpful to reinforce the subject matter within your readings. Okay, so I just found that it might be helpful when you're considering degenerative diseases in general, where they're located in particular to the brain, in particular to the particular disease. For instance, Alzheimer's disease is located in the temporoparietal part of the brain, and Parkinson's disease is located in the midbrain. So these are just things to keep in mind in terms of understanding ALS versus Alzheimer's and Parkinson's. ALS is more located in the motor cortex, brainstem, and spinal cord area, which definitely would kind of differentiate why the symptoms manifest the way they do to ALS versus PD and AD. Here is, what Alzheimer's looks like. So we're getting into our degenerative disorders, which includes Alzheimer's, Parkinson's, and Lou Gehrig's, right? So here we have a normal brain, healthy brain on the left versus the brain that has the advanced Alzheimer's on the right. You can see that Alzheimer's in general basically causes the brain anatomy to literally physically just deteriorate. So your brain actually shrinks in advanced Alzheimer's. Keep in mind, Alzheimer's disease is a progressive neurodegenerative condition and the most common form of dementia in the older population. 1 in 3 elderly individuals dies with AD or another form of dementia. Alzheimer's disease accounts for about $100 billion per year in medical and custodial expenses, with approximately $27,000 per year for each patient for medical and nursing care. In 2016, more than 15 million caregivers provided an estimated 18.2 billion hours of unpaid care, valued at more than $230 billion, according to the Alzheimer's Association. So, this disease, we want to diagnose it as early as possible, treat it as early as possible, and manage it as early as possible in order to avoid, having intense medical and nursing care that's required later on, because things were overlooked and left to basically deteriorate without any sort of intervention. Keep in mind, AD is characterized by an insidious onset. It is slow, progressive, cognitive decline, just like the average degenerative disorder. And there are an array of emotional and behavioral problems that result from the cognitive decline within Alzheimer's. It usually manifests as an impaired ability to learn new information or recall previously learned information, and one or more additional cognitive disturbances in language, which would be aphasia, or function, which would be apraxia, or perception, which would be agnosia, or executive function. Recent advances in understanding AD have modified both diagnostic and treatment choices. Most cases are sporadic, although there are rare familiar forms of the disease. Alzheimer's disease was named after Dr. Alois Alzheimer, who was in 1906 noticed changes in the brain tissue of a woman who had died of an unusual mental illness. On autopsy, he found these abnormal clumps and tangled bundles of fiber in her brain. And these findings are now called amyloid plaques and neurofibrillary tangles. So that's what you see in here. Sometimes you'll see in these little spaces, those fibers. So those are actually your plaques and your neurofibrillary fibers, tangles. Okay, so again, Alzheimer's disease, what are we diagnosing with? We're finding, in terms of manifestations, that we're finding difficulty or anomia, trouble doing routine chores, and progression to difficulty with simple tasks. Keep in mind, the Alzheimer's disease is staged, and it's usually staged around MMSE exam, so the mini mental state exam. So based on the scoring of that exam, that's how they stage Alzheimer's. So a mild stage of Alzheimer's would be an exam score of 21 to 30. Moderate stage of Alzheimer's would be an exam score, MMSE score of 11 to 20, versus a severe stage of Alzheimer's would be an MMSE score of less than 11. So in the next slide, I'll give you an example of what that score is. Please make sure you are reviewing in your textbook table 8.1, which has the advanced assessment of Alzheimer's disease, and table 8.2, which has the advanced assessment functional activities questionnaire. I'll show you that in the next slide. You're also going to want to review page 108, figure 8.1, which has your diagnostic reasoning algorithm for Alzheimer's disease. Again, I'll have that in the slide, but I always like to remind you what page to look at it, because even though I put it in the slide within the PowerPoint, sometimes it's not always very visible or 100% clear. So I want to make sure you can read it in your textbook. Another table, please look at page 109, which are your drugs commonly prescribed for Alzheimer's in table 8.1. So in terms of the management of Alzheimer's disease, the big goal is to maintain normalcy in relationships, in their everyday activities, good nutrition, exercise, and preventative care. We want to make sure we're doing lots of follow-up and referrals as needed for these patients. We want to instill memory aids and environmental modifications to make sure these patients are safe. So in terms of follow-up and referral, you are making referrals to home care services if necessary for physical therapy, occupational therapy, speech therapy, aid services, social work services, whatever it is you feel this patient would likely benefit from and utilize in order to make sure the quality of their life and their disease is managed accordingly, so that they can, be home and safe with their family for as long as possible, to prevent them from having to be institutionalized. I think that's usually the name of the game. I will say, though, once you make the diagnoses of Alzheimer's with these particular patients, you're going to want to make sure you continually readdress the advanced directives with these patients and their family members. You want to give these particular patients the chance to make the best decisions they can for their plan of care for the future as soon as possible, and while they're as lucid as possible. So, as time progresses, unfortunately, the disease progresses as well, they will not be able to make these decisions, and then it's up to the family member. So why not give these patients the freedom to make their advanced directive decisions now rather than later when they don't particularly have the brain function to make those decisions? And you may want to explain that when you bring up the concept of advanced directives without making it sound like death is imminent. You just want to make sure that everything is written out exactly how the patient wants it while they're still 100% able to make these decisions. Here in this particular slide, I listed the functional activities questionnaire, which is also in your textbook, as well as what the questions are that will be asked to these patients when you give them the MMSE exam, which is the mini mental state exam. So look at your scoring, okay? Because remember, the scoring is going to base this stage of the Alzheimer's disease. So if our score is 21 to 30, then we're pretty much getting most of them right, then we're on the very mild end. Versus if we get less than 11, which is virtually all symptoms and no answers correct, basically they have severe Alzheimer's. So just keep in mind, these are the things you need to make sure you are very well aware of that exist, that are utilized as tools, evidence-based practice tools to standardize the testing and diagnosis of AD, okay? Keep in mind, in terms of the clinical presentation of Alzheimer's disease, subjectively, the patient usually presents initially with complaints of memory problems. Often it's a family member who mentions this because patients with AD or Alzheimer's do not typically have insight into their memory difficulties. Recognition of cognitive difficulty on the part of the patient or family is often related to a change in pattern in the patient's behavior. So for instance, the patient could get lost in familiar places, they're unable to accomplish a demanding task at work, or they're increasingly becoming slower to respond to any sort of cognitive challenge. They may find that they're having difficulties with balancing the checkbook, preparing dinner, traveling alone, or maintaining employment are the most frequent reported problems by family members when the disease has progressed to the point where other people actually notice it. In the later stages of Alzheimer's, the patients usually will need help dressing, bathing, and staying continent. And eventually, as the disease progresses, the patient loses the capacity to converse, walk, sit, or hold up the head. Approximately 80% of patients in nursing homes with Alzheimer's have behavioral problems, which could include hostility, aggression, suspiciousness, paranoia, delusions, agitation, sundowning, incontinence, and inappropriate or impulsive sexual behavior. So these are things just to keep in mind that will definitely differentiate mild versus severe AD. Here is your diagnostic reasoning algorithm for Alzheimer's that you have in your textbook. I definitely want you to look at it in your book just to make sure you get a clear view of it. But I love these algorithms, also known as concept maps, because they give you a great map on what to do next. Like sometimes you don't really know, especially when you're first starting to practice, and all of a sudden these patients are coming at you with all these various broad symptoms, and you're like, oh my God, it sounds familiar. What, he's forgetful, he's delirious, he's got paranoia, he's got some aggressive behaviors. That sounds like it could be dementia, but where do I take it from here? And that's where you would look at these algorithms and use them to help differentiate, okay, so his consciousness is altered. Yeah, it is when his behaviors are irate. Multiple cognitive functions impaired, yes or no. If yes, we're referring to a memory disorder center or a specialist in dementing diseases for evaluation, or we're referring to a neurologist or psychiatric eval. Okay, next degenerative disorder that we focused on in our module this week and in our readings is Parkinson's disease. PD, or Parkinson's disease, is a chronic progressive degenerative disorder of the basal ganglia in the central nervous system. The disease usually begins insidiously and eventually leads to disability. Parkinsonian syndrome is any disorder that manifests symptoms of Parkinsonism, which includes resting tremor, rigidity, bradykinesia, postural instability, flex posture, and freezing. Idiopathic PD is the most common cause of Parkinsonism, but numerous other causes include Parkinsonism plus syndromes, secondary Parkinsonism, and certain genetic disorders such as Wilson's disease. Patients with idiopathic PD make up the largest subgroup, which basically represents about 80% of the affected population. Parkinsonian plus syndromes are caused by degeneration of multiple symptoms and are characterized by neurological signs and symptoms in addition to Parkinsonism. Examples in this category include progressive palsy, multiple symptoms atrophy, and corticobasal disorder, such as cerebrovascular disease, drugs, infections, trauma, or exposure to toxins. Common causes of secondary Parkinsonism include exposure to dopamine blocking medications such as antipsychotics or antiemetics. And there are numerous rare hereditary causes of Parkinsonism. One of the more common causes that's a hereditary cause of Parkinsonism is Wilson's disease, which causes an abnormal accumulation of copper. And this disease should usually be ruled out in all young patients presenting with a movement disorder because it is very easily treatable. Keep in mind, PD is a degenerative disease of the nervous system, and its neurological effects include tremor at rest, muscular rigidity, slow movements, and difficulty maintaining a steady posture. Characteristically, the motor problems of PD improve when a patient is treated with levodopa. Pathologically, Parkinsonism causes abnormal accumulation of Lewy bodies and degeneration of pigmented dopaminergic cells of the substantia nigra, which is located in the brainstem. Management of Parkinsonism or Parkinson's disease includes controlling of the symptoms with our medication, deep brain stimulation, and cholinesterase inhibitors. Follow-up and referral, like I said before, is when you're going to want to reach out to your home care services or inpatient services, whether it's inpatient or outpatient, home-based. You're going to want to have these patients followed up with speech therapy, physical therapy, occupational therapy, physical therapy, any kind of home health aid services, because these patients need assist with ADLs and IADLs, as well as getting a social worker involved to ensure long-term family support, home care support, and advanced directives. Here again are just more ways of looking at Parkinson. Here's a beautiful diagram of the classic Parkinson disease symptoms, as well as another algorithm for the treatment of motor symptoms of Parkinson's disease. Again, remember those 6 cardinal features of Parkinson's, which includes a tremor at rest, rigidity, bradykinesia or hypokinesia, flex posture, loss of postural reflexes, and the freezing phenomenon. The major manifestations of tremor, rigidity, akinesia or bradykinesia, and postural disturbances form the mnemonic TRAP, T-R-A-P. So TRAP could be tremor, rigidity, bradykinesia, and flex posture. Akinesia and postural disturbances for P. So T is tremor, R is rigidity, A is akinesia, and P is postural disturbances. And that mnemonic TRAP, T-R-A-P, are the major manifestations of Parkinson's. So try to remember that. A tremor may be the reason the patient or family seeks care for the first time, and it is usually recognized as the first symptom of Parkinson's in about 70% of patients at initial diagnoses. So just keep that in mind. If you see a resting tremor, guess what, guys? Definitely consider Parkinson's, especially if you have that shuffling, stooped posture and gait. There's also a classic rest tremor of Parkinson's that can mimic the motion of a pill rolling motion. It looks like the patient takes their fingers and kind of is just pill rolling a pill. It's actually technically a symptom of Parkinson's. So just keep that in mind. All right, the next degenerative disorder we reviewed is ALS, or amyotrophic lateral sclerosis, also known as Lou Gehrig's disease. It is a progressive neurological disorder that involves destruction of the motor neurons. Both the upper motor neurons and lower motor neurons are affected, distinguishing ALS from other motor neuron diseases. The cause is not known, although approximately 10% of cases are genetic. So you definitely want to make sure when you're doing your genetic review or family history review with your patients, that you're definitely acknowledging if anybody in the family had ALS and making note of it to ensure that those symptoms are not missed in your patient if, God forbid, they do start to manifest. Researchers are definitely studying possible causes, which may include abnormal RNA processing, mitochondrial dysfunction, viral infection, a disorganized immune response to toxicity, and others. Slightly more men than women have ALS, and age, family history, and possibly tobacco use are really the only known risk factors. The scary thing about this disease is that it is universally fatal, within a median survival rate of 3 to 5 years. Diagnosis is confirmed with an electromyography. Symptoms typically start in one limb or region in the spinal cord, although in 20% of patients, symptoms begin in the cranial nerve. Presentations vary pretty considerably between patients, as motor functions of any area of the body may be affected. There's a very famous man named Stephen Hawking who had Lou Gehrig's. They made a wonderful movie. It's called Theory of Everything. I would definitely encourage you guys to check it out. It does a beautiful depiction and physical manifestation of, how the disease progresses, how the disease is to live with from such a young age, and also how the family and the people around the patient are, have to live with it and cope with it. This is a very sad disease. There's not a whole lot known about it. They're doing a lot of research, but still it is very progressive. There is no cure. It's a very rare neurological condition, and it is very, very painful for the families. Again, another disorder that you definitely want to sit down with families as soon as it becomes apparent that this diagnosis is 100% valid, and you want to sit down with them and go over advanced directives to make sure that the patient is very, very well aware of the potential of what may or may not happen. Okay, next big subject, we reviewed this neurological, in our neurological module this week, is cerebrovascular accident, AKA stroke. It's called, basically a stroke, also referred to as a CVA, causes an acute onset of neurological deficits caused by a decreased blood flow or bleeding in a localized area of brain tissue. Although the incidence of stroke has decreased in the past 25 years because of risk factor management and improved treatment, it has continued to be a significant health problem in terms of both mortality and permanent disability. Stroke is a leading cause of disability in adults, incurring major economic burdens on the patient, family, and public as a result of direct medical cost and loss of employment. The risk and the impact of cerebral vascular disease is a major health problem with demands on healthcare and other support systems will continue to grow as the number of stroke survivors living with disabilities increases and the population continues to live longer. The need for continued improvement in stroke prevention, the control of risk factors, and acute management of stroke is critical. So keep in mind, in terms of epidemiology and causes, you have your non-modifiable risk factors, including age, sex, race, ethnic origin, and heredity, versus your modifiable risk factors, which includes hypertension, cardiac disease, diabetes, and lifestyle. And you definitely need to make sure you review the differences in pathophysiology of your ischemic versus your hemorrhagic strokes. Keep in mind there are two kinds of strokes, hemorrhagic and ischemic. Approximately 80% of strokes are ischemic, which means, so just keep in mind, most of your strokes that patients are having, 80% of them are ischemic. So make sure you know what ischemic is versus your hemorrhagic, which is about 20%. Ischemic stroke, also called an ischemic cerebral infarct, is caused by a decreased blood flow to a localized part of the brain supply. Etiologies include an embolism, thrombosis, and hypoperfusion. Keep in mind, a TIA, or a transient ischemic attack, is a temporary episode of a focal cerebral ischemia that resolves spontaneously and does not leave permanent damage. So keep in mind, we call TIAs mini strokes. Remember, back in the day, I don't know if they still call it that, but that's what we always used to call it. People who've had a TIA are at higher risk for future strokes. So keep in mind, whether you have a TIA or just a full-blown stroke, you are at high risk for having another one within the near future. So keep that in mind. If that's the case, if your patient has just had a recent stroke, you want to make sure that you're educating them on how to avoid risk factors for having another stroke, which includes things like no flying, no sitting in the car for long periods, no standing for long periods, all the basic things you teach your patients in terms of prevention of blood clots, okay? And of course, you want to make sure they're taking their medications appropriately, their blood pressure is under control, and they're having follow-up appointments pretty periodically to ensure everything is stable. Hemorrhagic strokes can be further classified as intracerebral hemorrhage or a hemorrhage into the brain parenchyma itself versus subarachnoid hemorrhage, which is bleeding into the cerebral spinal fluid in the subarachnoid space surrounding the brain. Or we have epidural and subdural. So again, we have our hemorrhagic versus ischemic strokes. Ischemic strokes include embolism, thrombosis, and hypoperfusion. We have our TIAs, which are mini strokes that resolve spontaneously and do not leave permanent damage. And then we have our hemorrhagic strokes, which include intracerebral hemorrhages, subarachnoid hemorrhages, or epidural and subdural hemorrhages. So make sure you look at your text to differentiate those two different types of categories of strokes. So things you need to make sure you really are understanding in terms of diagnosing strokes. Keep in mind, patients who present within the first few hours of stroke symptom onset may be eligible for acute stroke treatment with IV tissue plasminogen activator and require emergent evaluation in emergency department, but they have to get there within a certain time frame for them to be eligible for it to work. So that the key thing, if you're thinking or you're even possibly considering a patient is having a stroke, get them to the emergency room as soon as possible. And one of the key things that we have found is that most patients whose treatment for their stroke didn't really work, it's because they had a delay. It's because they decided to go to the urgent care center or their primary care physician as opposed to going directly to the emergency room. So these are things we need to educate our patients on. And which patients in particular are you educating on in terms of stroke prevention? Your hypertensive patients, right? Your patients who you're trying to manage their blood pressure. You always want to give them at every visit just the heads up. Hey, worst case scenario, keep in mind, high blood pressure puts you at high risk for stroke. These are the symptoms. If you're experiencing any of these above, you need to call 911. Don't call me, call an ambulance, okay? These are things you have to educate your patients on. They are their own best advocates. Please tell them. If they don't know and you don't tell them, then they won't know what to do. Okay, guys? So educate your patients, educate their family members. So it is strongly recommended that emergency CT be the initial brain imaging study for the emergency evaluation of a suspected ischemic stroke. Practice guidelines of the American Heart Association Stroke Council recommend the use of a non-contrast CT of the head in patients with a suspected acute stroke to exclude a non-vascular lesion as the cause and signs and symptoms to assess for an intracranial hemorrhage. So keep that in mind, guys. Diagnostic tests, you want to make sure you're doing your practice guidelines based on the American Heart Association Stroke Council. The first thing we want to consider is a non-contrast CT of the head. Of course, we're going to get a CBC, we're going to get a line in them, we're going to get them oxygen, we're going to get them stabilized to make sure that we can get them their treatment as soon as possible. Differential diagnoses of stroke includes focal seizures, complex migraine auras, and brain tumors. We did talk about migraines and headaches last semester, so please, if you need to review that, please review that so that you can make sure you're differentiating symptoms of a CVA versus a migraine. So again, management would include adequate tissue oxygenation, as well as antiplatelet drugs to prevent another blood clot from causing another TIA or stroke. Follow-up and referral is really, really important. Follow-up and rehabilitation focuses on the return of the patient's optimal level of functioning.
It's 7
So
o'clock.
following treatment and stabilization, the patient should be assessed for the potential for rehab and transfer to a short-term rehab unit. The rehabilitation process involves 6 major areas of focus. Please, guys, please make sure you review this, okay? It's in your books, it's in the table. Just review your 6 major areas of focus when it comes to rehabilitating a stroke patient. So the first thing is prevention, recognition, and management of comorbid illnesses and medical complications. So you want to look at all of their diagnoses across the board to make sure everything is being handled, medications are being taken and prescribed appropriately and effectively. You want to make sure you're training them for maximum independence. So that really comes up to how the staff are appropriately trained in the short-term rehab, but usually they're pretty good in terms of just really reinforcing and kind of expecting the patient to perform their ADLs with as minimal assist as possible to help facilitate their independence. We want to facilitate psychosocial coping and adaptation by the patient and family. So this is where counseling, support services, support groups, social worker, and just educational tools are really helpful for both the family and the patient in terms of how to manage day to day, as well as just cope overall in general, especially from a financial standpoint. Please, I did upload that Parkinson's disease guidebook. Please make sure you take a look at it just to make sure you're understanding, the extent of what needs to be done for these particular patients. We want to prevent any secondary disability by promoting community reintegration, including resumption of home, family, and vocational activities. So again, the goal is to just try to get these patients back to their normal life as much as possible. We also want to enhance their quality of life in view of their residual disability. So despite the fact that they may be disabled from whatever the stroke left them with, we want to try to still get them to see the positives of what they have left and what's going on in their lives currently. Hopefully there is positives that you can kind of have them focus on. And number 6, we want to prevent the recurrence of a stroke and other vascular conditions such as an MI that occur with increased frequency in patients with stroke. So remember, when a patient has a stroke, it puts them at higher risk for having an MI. If we just threw a blood clot, guess what? We could definitely have a clot that just traveled to our heart and caused us to have an MI. So these are things we need to make sure we're trying to prevent. And again, what are we preventing them with? Medication, education, and lifestyle changes. So here is those 6 areas again reviewed, as well as including the iceberg of stroke that your book loves to portray, just in terms of portraying just all the different components. They like to use this little thing called an iceberg, whatever works for you. For me, it's just a concept map, basically breaking down the different components of what the stroke patient will need in terms of holistic care. So education, self-care, psychosocial support, pharmacological support, possible surgery with a carotid endarterectomy if needed, right? Rehabilitation for sure, psychosocial support to help their self-esteem, improve their self-image, decrease isolation, and increase activity and involvement, as well as social support. Of course, we want to look at their diet, decrease their sodium and fat, increase their fiber, fruit, and veggies, stress reduction, lifestyle alterations, including exercises, meditation, smoking cessation for sure. All right, guys. So next week, we have Module 11, which is musculoskeletal pain management. Please look at your readings. The syllabus says Chapter 52. It says Chapter 53. It is not Chapter 53. You should be reading Chapter 52. Chapter 52 is common musculoskeletal complaints. Chapter 76 is your sports physicals. Chapter 78 is palliative care and pain management. So again, please just make sure it's not Chapter 53 you're reading, it's Chapter 52, common musculoskeletal complaints. In your CASH textbook for your guidelines, you're reading your musculoskeletal guidelines, and in your COLIAR, you're going to look at Section 2 for musculoskeletal procedures. Please focus on your diagnostic testing and your procedures to review in Chapters 30 to 39. All right, guys, have a great week. I will be posting all your quiz reviews within the modules, and I will make an announcement once those are posted. I hope you have a great week. Please email me if you'd like to meet or if you have any questions. Thanks, guys.